Thanks very much, everybody. I'm Paul Thomas. I'm the Vice President of the Australian Association of Nuclear Medicine Specialists, and I'd like to welcome you all to this session. My co-chair, Sam Belangieri, is on his way. He's come all the way from Melbourne, so he's running a little bit late this morning. He did have a big night last night, though. The whiskey was touched. There's a few announcements I need to make. Please turn your phones off. That's standard. You can download the MCI Group Event app, so don't search for World Federation of Nuclear Medicine Biology. You have to search for MCI Group Event Portal. Put in the access code, WFNB18, and they should have emailed you your access code. If not, you can recover your password to get into the access code. And you can refresh the data in that by, if you press on the little gear symbol, there's a refresh, and it'll give you the most up-to-date information. And there's instructions on CME points, but I'm sure nobody will be wanting to do that, but you can access the CME points through scanning the QR code with the app. Now, Sam is still not here, so we'll battle on. It's my very great pleasure to welcome our co-president of the Society of Nuclear Medicine, Ben Greenspan from Augusta, and he's had a long interest in quality and value in nuclear medicine, so welcome to the stage, Ben, and thanks for coming all this way to be with us today.
Well, thank you very much. I'm delighted to be here. It's a pleasure and an honor. So my presentation is on quality and value in nuclear medicine. And I'm using the Canadian version of disclosures, so I have none. Anyway. So there are objectives here. In the United States, if we're giving talks for CME credit, we have to list objectives. I just thought it'd be reasonable to put them in anyway. So discuss how nuclear medicine and molecular imaging bring value to imaging practice and bring value in oncology with the use of radionuclide therapy. So before I talk about value, I think it's important to talk about quality, because quality is critical to good practice and value cannot exist without quality. There are a couple of interesting quotations. Quality is never an accident. It is always a result of intelligent effort. And quality is absolute and universally recognizable, a mark of uncompromising standards and high achievement. So in the U.S., there are three goals of the National Quality Strategy: better care, improve the health of the U.S. population, and affordable care. And so I presume that basically a quality strategy here or anywhere else would be similar. Now, there are three types of quality processes: quality improvement, quality assurance, and quality control. Quality improvement and quality assurance are virtually identical. So the definition of quality improvement is a formal approach to the analysis of performance and systematic efforts to improve it. And there are a number of aims of quality improvement, and this actually is a combination of two separate lists of 6 each, and there was a lot of overlap, but basically it includes safety, avoidance of harm, effectiveness, prevention, diagnosis, and treatment based on scientific knowledge, and avoidance of underuse and overuse, efficiency, avoidance of waste and excess cost, and also avoidance of underuse and overuse fit under that one as well. Equitable, provide care that is consistent in quality. In other words, everybody gets treated properly and with respect. Patient-centered, respectful of and responsible to individual patient preferences, needs, and values. Timely, reduce delays. Promote effective communication and coordination of care. Promote best practices. And promote more affordable quality of care. So at least that's what we're trying to do in the U.S. And one of the QI approaches is called Plan, Do, Check, Act, PDCA. Also, it's known as PDSA, Plan, Do, Study, Act. It means the same thing. And it's a 4-step process of quality improvement. Plan what to evaluate, then do it, study the results, and act on the findings and make changes if necessary. And then you can repeat the process. And this is one way to keep up that and know that your studies are good quality and the whole process is good quality. There are 3 types of quality improvement: administrative, which is using appropriate use criteria. I don't know if you have that in this country here, but in the U.S., we're now expecting to be required by our Medicare insurance that referring clinicians will use appropriate use criteria to order advanced diagnostic imaging services. And so that's one thing, that one part of it. Patient satisfaction would be another, timeliness of reporting and completeness of documentation. Technical issues include image quality, adequacy of patient preparation, radiation dose optimization, and therapy results. And interpretive, of course, include report accuracy and inter and intra-observer variability and correlation. So not only should we have relative consistency between interpreters, but also for the same person, giving the same study to them to review sometime afterwards and looking at the results, it should be very consistent. So quality assurance describes how an organization or department knows that it's doing its job correctly. It's a process that examines departmental outcomes and promotes continuous improvement. It's an overall program of quality. In medicine, it includes quality of care to patients, appropriateness of diagnosis and treatment, and the level of patient satisfaction. And quality assurance is required by our Joint Commission, and that's an agency that is basically required to. We're required to have them assess our practices to get Medicare reimbursement. If you don't want Medicare reimbursement, then you don't need to use them, but that would be kind of financially foolhardy. Okay, and then there's quality control. Quality control refers to tests that confirm adequate equipment performance of equipment or radiopharmaceuticals. These tests are used to identify problems of equipment or radiopharmaceutical performance, and they're performed on a regular basis, commonly daily, weekly, or monthly. And so uniform flood fields for evaluating your gamma cameras, or evaluating the dose calibrator for constancy and so on, are all QC tests. And QC is a part of quality assurance. So there are some general principles in nuclear medicine, and as I understand most of your nuclear medicine physicians, I'm sure you all know this. You should practice high quality nuclear medicine, which means high quality studies that are well performed. Reports of studies are accurate and timely, high standards of practice, and know that nuclear medicine technology, physics, protocols, and elements of quality. Also includes radiation safety and patient safety, high quality of instrumentation, including quality control, high quality of radiopharmaceuticals, also including quality control, and provide education and continue education. So, for instance, if you're doing a great job overall, but your radiopharmaceuticals have poor labeling, that's a problem. And you need to know that. So now I have a couple slides here on reporting. This information here comes from the American College of Radiology, and they have a practice parameter for communication of diagnostic imaging findings. In the ACR lingo, a parameter is basically a guideline. And we're both ACR and Society of Nuclear Medicine Molecular Imaging kind of shying away from the term guideline because our Institute of Medicine has very strict criteria for performing clinical practice guidelines. And if a society doesn't have guidelines that are consistent with those criteria, they're going to be listed as non-compliant, and nobody wants that. So to make sure there's no confusion, the ACR changed the term guideline to parameter, which is some term they had a few years back. So it means guideline. And what are guidelines? They're guides to good practice. Anyway, so the ACR lists effective communication is a critical component of diagnostic imaging. We all know that. Quality of patient care depends on timely transmission of study results. And effective communication includes promote optimal care and support the referring clinician, satisfy the need for timeliness, and minimize risk of communication errors. Now, both the ACR and the Society of Nuclear Medicine Molecular Imaging follow this, basically. The purpose of reporting, of course, is to document in the medical record information from the exam or procedure, transmit that information, especially answering the clinical question, to referring clinicians and do so in a timely manner, and provide appropriateness, necessity, and performance of the procedure for correct coding and billing. So in our system, there should be a proper indication on the report so that the coders and billers know how to code it and bill it properly so we get reimbursed appropriately. So what are quality and value indicators in nuclear medicine? You need to serve the needs of the referring clinicians because, of course, our whole purpose really is to help clinicians manage their patients. So we need to answer the clinical question if that's possible. Usually it is. Sometimes they ask something that you can't answer, and then you just do your best. Produce useful results or reports. Be available. Bring in new studies for subspecialists. Identify clinical champions of nuclear medicine and keep them happy by providing accurate reports and good service. Another part of this also is attending tumor boards and multidisciplinary conferences and make sure the nuclear medicine studies are presented properly. Serve as an imaging investigator in research projects of clinicians. And you should be a source of pride in your department. Provide innovation, new clinical studies, and publish. That's mainly in the academic centers, of course. Be a center of quality. Contribute to the greater radiology community. Now, in the U.S., most of nuclear medicine, not quite all, but almost a huge percentage, majority of it is done within radiology departments. And so that's why I have this listed here. I'm not sure if you're included in radiology or not. Anyway, so for us, it's important to contribute to the greater radiology community, be collegial and a team player, facilitate scheduling, especially in multiple studies. And this was more important years ago when we would work up patients by doing several general nuclear medicine studies to diagnose patients, and we would help coordinate them so they were done in the proper order so one wouldn't interfere with the other. And invite non-nuclear medicine radiology colleagues to be involved in research or QI projects and be a good citizen in the department. Follow best practices, which includes following the policies, procedures, and protocols, including the procedure guidelines. And again, that's parameters in ACR, and SNMMI uses the term standards. I understand the Europeans don't like the word standard. They'd prefer guidelines. So there are changes all around the world on this. But the meaning is all the same. They're all guidelines. They're guidelines to good practice. Use appropriate use criteria. We're going to be required to do that. And I think the current estimated start date is January 1st of 2020. It'll be required to get reimbursement. Practice accreditation, which means accreditation of your practice, and therefore documentation that it's good quality. Follow QI and QA procedures, and quality control, of course, which includes acceptance testing. And a technologist asked me once a few years back, we're getting a new camera, do we really need to do acceptance testing? And the answer is absolutely yes, you absolutely must. As good as the companies are, you have to rely on your own documentation to make sure the camera is working up to par. And also best practice includes providing the correct radiopharmaceutical and the correct administered activity to the correct patient for the correct indication. Now, as far as value, how do you define value? And there are a number of ways to do this. And I thought I knew something about value until I heard a lecture at the Canadian meeting recently, and it was way beyond what I'm going to show. But at least for basics, as far as value, what is the value of an item? Well, if you go to a department store or a grocery store, the value is the cost. Well, in medicine, things are more complicated. For us, it's the benefit over the cost. And benefit can be actually further defined as quality and service. So for us, we're providing high-quality studies and good service, and there's some cost to that. You know, there's some charge to the government or whatever, or insurance companies. And so we want to make sure that we maximize our value. So value, part of value is supporting and promoting quality, of course. And have appropriate use of nuclear medicine and molecular imaging studies for specific clinical indications and problems. Use procedure standards as guidelines of good practice, and implement AUCs, at least in our country. I suspect something like this will become somewhat universal, because it'll help reduce the ordering of unnecessary exams. Also, value includes providing leadership, which includes integrity. Now, I've looked this up several times. The word integrity, by definition, includes honesty and high ethical standards, and also includes fairness. And that's great, because I believe in fairness. Leadership includes vision, planning, chart the course, and plan for future needs, communication and motivating others. And this last one comes from someone I met from the military who wrote a book on leadership, and he included respect, honor, and personal courage. I think those do make sense, so I included it here too. As far as quality of practice, you want to make sure the credentials of the chief and the faculty are appropriate, have appropriate use of nuclear medicine, molecular imaging for specific clinical indications and problems, provide high-quality studies, procedure guidelines and appropriate use criteria, accurate and timely reports with recommendations for further studies when appropriate, and introduce new state-of-the-art studies. You know, it's a little bit of redundancy in these slides, and that's done deliberately. I think a little bit of redundancy is good. In academia, quality of practice also includes provide high-quality training for residents, fellows, medical students, and others, and encouraging students to pursue a career in nuclear medicine, molecular imaging if they're interested. Now, as far as operationalizing value-driven practice, again, implement procedure standards or guidelines, AUCs, high-quality imaging, accurate and timely reports, and accreditation of your practice. Also support maximizing reimbursement, not only correct coding, but utilization higher value studies when appropriate, but only when appropriate. We certainly don't want to encourage people to do things that are shady at best or illegal at worst, obviously, but at the same time, you should get paid appropriately for what you're doing. You want to be a valuable resource for the department, institution, and the field of nuclear medicine, molecular imaging, basically throughout the world. And in the U.S., it says provide input to societies such as SNMMI and ACR, or here, your societies, our Congress and government agencies, because they have a lot to do with the kind of work we're doing and the regulations we have to follow. Now in the U.S., we have a Nuclear Medicine Global Initiative, and this is to encourage global collaboration and education to harmonize procedure guidelines and other policies or to improve quality and safety. And a number of organizations are involved, including a number of nuclear medicine societies, including those of China, Japan, Korea, India, Australia, New Zealand, Canada, and South Africa, and also multinational organizations, the European Association of Nuclear Medicine, the IAEA, International Atomic Energy Agency, WFNMB, World Federation of Nuclear Medicine and Biology. This is the Latin American Society, and AOF-NMB, Asia Oceanic Foundation of Nuclear Medicine and Biology. And so we've had one very successful first project, which was standardization of administered activities in pediatric nuclear medicine. It turned out there was a survey a few years back, and the results were all over the map. So they realized, wait a minute, we need to standardize these. And so that's been very successful, because some places use way too much and expose infants and children to more than necessary, and other ones were using too little, and the studies weren't good quality. So you got to avoid both extremes, of course. Second project is availability of radiopharmaceuticals, and that's ongoing, and I think they're making good progress here. And we're actually proposing a third one on Theranostics. Now, in the Society of Nuclear Medicine and Molecular Imaging, we've also started a new initiative. We have a new vision for leadership in our field, and that's the Value Initiative. And our Value Initiative is the strategy and roadmap for working with industry and other partners to demonstrate the crucial role of nuclear medicine and molecular imaging to the medical community, regulators, patients, and the public. And we believe by working together, we can bring greater value to the fields of imaging and medicine, advancing scientific discovery, and further improving patient outcomes. Because that's the whole goal, improving patient outcomes. So we have 6 domains within this value initiative. The first one is quality of practice. Second one is research and discovery. Third one is workforce pipeline and lifelong learning, or lifelong education. That also belongs in the first one as well, lifelong learning and education. Advocacy, which is transmitting the value of nuclear medicine to Congress, regulatory agencies, and so on. Outreach, which is more to patients, the public, and particularly hospital administrators. And then the last one is organizational strength and stability, which is to make sure that our Society of Nuclear Medicine and Molecular Imaging has the support, the financial support, and the stability to continue all these activities. And a little more detail. Quality of practice is about raising the standard of diagnostic and therapeutic practices in our field. Research and discovery is about research, development, and marketing of related drugs and devices, essential to the vitality and growth of the specialty. Attracting and education new talent is the heart of workforce pipeline and lifelong learning. And of course, again, lifelong learning includes, and quality of practice is included there. Advocacy centers are on promoting awareness among policymakers about our field, especially on the issue of reimbursement. Outreach is focused on communicating the value of the specialty to patients, providers, academia, and industry. And organizational strength and stability ensures long-term leadership by the society for our field. So in research, which is mainly in academia, of course, the value is by providing research in the department, inviting colleagues, including referring clinicians, to participate, develop new tracers for diagnosis and/or radionuclide therapy. And as I don't know many of you know, but about a year and a half ago or so, in late May and early June of 2016, we had new diagnostic radiopharmaceuticals approved. These are the brand names, but F-18 fluciclovine for prostate cancer, more specifically castrate-resistant metastatic prostate cancer, and gallium-68 dotatate for neuroendocrine tumors. And we're working on several others. And then we have a clinical trial network that's helping promote these and getting approval for them. And on January 26th of this year, lutetium-177 dotatate was approved for treatment of gastroenteropancreatic neuroendocrine tumors. And this agent was approved in Europe in September of 2017. So PET-CT is the single most sensitive and accurate modality in many malignancies, as you all know, for diagnosis, identification, evaluation, staging and restaging, detecting residual recurrent disease, monitoring response to therapy, and evaluating prognosis. And it'll be vital for directing therapy in oncology, especially in the use of radionuclides, including theranostic agents. Now, in case I haven't defined this term, but theranostic agents are basically radiopharmaceutical pairs, which may or may not have the same radionuclide, for diagnosis and then therapy. And the first one was I-131 sodium iodide, which was used for diagnosis and then also therapy of hyperthyroidism and also thyroid cancer. Now we're getting new ones where the radionuclide may be different, but the radiopharmaceutical is very similar, and the point is you can do a diagnostic study, evaluate the disease process, usually in tumors, and look at staging and so on, and then treat with another radionuclide that's a better therapy agent. And so one good example, of course, for neuroendocrine tumors is gallium-68 dotatate and lutetium-177 dotatate. So I think nuclear medicine will demonstrate quality and value to referring physicians, patients, and the public, and especially radiologists, by providing precision medicine and personalized care. Current and new tracers will be used to precisely characterize disease, and this will be especially true in malignancies. And my area of expertise is more in malignancies, but I'm sure we'll have advances in cardiology and neurology as well. In addition to advances in diagnostic and therapeutic radiopharmaceuticals, including theranostic pairs, we will also see advances in instrumentation, including whole-body PET. There are two institutions in the U.S. developing a whole-body PET. The main one is University of California, Davis, but also University of Pennsylvania are working on this. And I think Davis, I know, is making very good progress. I'm not sure where things stand at Penn. Currently, we're seeing advances, diagnosis, staging and restaging, monitoring, therapy, and surveillance. And here's a slide from Johannes Turnen from UCLA showing some of the advances we're starting to see now, at least in their experimental. Well, this one now has just been approved. So here's gallium-68 dotatate showing some lesions in the liver, and then after treatment with lutetium-177 dotatate, the lesions have resolved completely. And these are both now approved in the U.S. And then here, gallium-68 PSMA, which is not yet approved in the U.S., shows a large number of lesions and a PSA of 425 nanograms per milliliter. And then following lutetium-177 PSMA, there's been a huge improvement. And neither of these are approved in the U.S. at present. Here, the slide from Richard Baum in Germany, using alpha radiation therapy. So here's a case where someone had the prostate cancer patient had a number of lesions. PSA was 294 nanograms per milliliter. And after two cycles of lutetium PSMA, patient was not responding. So then he used actinium-225 PSMA. Now this is an interesting isotope because it actually, in its decay, it gives off 4 alphas and 3 betas. And here, the PSA went from 294 to 419 to 3.5 to less than 0.1. That's amazing. And that's the kind of thing we can expect to see more in the future. Now, this is another slide from Richard Baum. I think this is really interesting also. He says, cancers will be classified by molecular phenotypes, and the site of origin will be secondary classification. Molecular phenotypes will be determined by molecular pathology and molecular imaging studies, mainly PET, also SPECT, MRI, and optical, using cancer type specific probes. Treatment will be targeted specifically against the tumor, and that's what we're calling precision medicine. And he said that neuroendocrine tumors and prostate cancer are a paradigm for this approach, as a molecular radiotherapy is applied based on molecular features of tumors and not primarily based on the organ of origin of the tumor. That's all true. I think I-131 for thyroid cancer is also a paradigm in many ways too, and it's by far the oldest one. The first treatment for hyperthyroidism was actually performed in 1941 by Saul Hertz at the Mass General, and I think he treated thyroid cancer initially in 1942 or 43. So, provision of targeted radionuclide therapy will be utilized unique to each patient, which will include alpha and beta emitters, many as theranostic pairs, some as radiolabeled antibodies, probably in combination with each other and probably with other modalities, such as immune modulation, radiation therapy, chemotherapy, or even viral infection. Some people are using viruses to attack tumors. I expect advanced versions of PERSIST criteria will be utilized to characterize the metabolic response to therapy. Up till recently, RECIST was the main version of evaluating criteria for response to therapy, but it's anatomic. They use a CT to measure the size of the tumor, and if it shrinks a certain percentage, you can say there's been response. Well, the problem there is that it's not metabolic, and you can have residual tissue in the center of the tumor that's fibrotic, and it's not going to shrink. Now, PERSIST is based on metabolic characteristics, so that really makes much more sense these days. And Letha Shankar from the National Cancer Institute stated, in the near future, based on biologic characteristics of tumors, we'll be seeing increasing use of predictive and prognostic markers, assessing therapeutic response, and using focused surveillance and screening. So targeted precision radionuclide therapy will target various enzymatic pathways and cell surface receptors, including clonal variations. This is how we'll succeed with these. And these therapies will also rely on precise dosimetry. These new tracers, especially theranostic pairs, will provide solid evidence of efficacy, quality, and value, and will be fully incorporated into clinical guidelines such as NCCN. These techniques will produce better outcomes for patients with much less morbidity. And I predict that the development of new PET tracers and new radionuclide therapies will be critical for the evaluation and treatment of malignancies, and these will provide much more precise management and therapy for many patients with much less morbidity and much better patient outcomes. So I think that's my last slide. So basically, the promise of all this is that we're going to have much better, much more sensitive and accurate diagnostic studies and therapeutic techniques for much better outcomes for patients with much less morbidity. Thank you very much.
Thanks very much, Ben. I think in the interest of time, if you don't mind, we might hold the questions for the sessions to the end and see how we're travelling, if that's okay. And do you want to introduce David?
Yes, I will. I'd like to welcome David Patterson to the podium. He is both a nuclear medicine physician and an endocrinologist with an interest in thyroid carcinoma, and we've invited him to the symposium to present his thoughts on some of the current controversies in thyroid cancer. Thank you, David.
Great. Thanks, Sam, and thanks the AANMS for the opportunity to speak to you today. So I'll be talking about current controversies in thyroid cancer. And really, as an overview, it ties in nicely with the end of Ben's presentation, talking a little bit about theranostic principles. So I'll cover the sort of status quo of where most thyroid cancer is today, and then I'm going to look at a couple of controversial topics. The first one being the use of I-131 therapy in secondary malignancy. Then moving on to discussion about the role of pre-therapy imaging and dosimetry and how that can relate to more theranostic practice in thyroid cancer. Before finally looking at a discussion about the use of recombinant human TSH or thyrogen and metastatic disease. So by definition, they're all controversial, so everyone will have different views, but I'll be presenting one view of this for you today. So really, with differentiated thyroid cancer, everyone would have seen this slide. This is based on the Australian data, where we've seen over the last 40 years really quite a dramatic increase in the incidence of thyroid cancer. But despite this, the actual mortality has remained stable, and it really does suggest, well, potentially an increase in overdiagnosis, and by definition these tend to be the more low or intermediate risk tumours that are being diagnosed. When looking at differentiated thyroid cancer, just a quick overview, we know that the majority of these, or 85%, are papillary, a smaller component of follicular, and then we can have less or non-differentiated or anaplastic types. The majority is cured with treatment, predominantly with surgery and also with radioactive iodine, and we have a smaller component of about 15% who develop recurrent or metastatic disease, and it's from this cohort that patients unfortunately die. And guiding our practice at the moment, we have the updated American Thyroid Association practice guidelines. So these actually came out in 2016, but really the trends that are evident from these guidelines are the use of clinico-pathologic recurrence risk classification. So really we're looking at the pathology of the resected tumour to guide therapy, particularly based on risk of recurrence when we're using radioactive iodine. The principles of dynamic risk stratification, so tailoring management individually based on the patient's response to initial therapy. And then also there's a trend toward de-escalation of therapy, and you'd be familiar with fewer indications for radioactive iodine for remnant ablation or adjuvant therapy, and also increasing discussion about the role of even active surveillance of small papillary thyroid carcinomas. So the first topic I'll discuss is that controversial issue of I-131 therapy in secondary malignancy. And really, the question is it safe or is there a risk from blind I-131 therapy? And this was a recent online publication from Journal of Clinical Oncology, which came out was published online in December of last year. And the premise of this was that radioactive iodine, they acknowledge that it improves overall and disease-free survival in advanced stage thyroid cancer, but they raised the question of little or no definite evidence for its benefit in low and intermediate risk tumours, predominantly due to a lack of randomised controlled trials. And again, there is this controversy about this, and it's reflected in the ATA guidelines. They also had concerns about a small increase in relative risk of solid tumours and leukaemia that previous meta-analyses have looked at, and felt a need to further characterise the risks of radioactive iodine for secondary haematologic malignancies in particular. Now this, certainly is a controversial article, and there's thanks to Dr. Mark Tulchinsky from Pennsylvania, who really led a careful analysis and well-coordinated international email correspondence of quite a large group of nuclear medicine physicians over about a 6-week period regarding some errors in the published data, which was very good. And as a result of this, there was a request for the article retraction submitted in late January. Now, I'll go through this in more detail, but the request was refused, but subsequently the manuscript's been updated online, but to date without any actual qualification, which is a little bit concerning. They've changed the data in response to the request, but without actually reflecting that on the journal. And so subsequently there have been several letters to the editor that have been submitted. But when we do look at the study, so it was looking to assess the risk and outcomes of individual second haematologic malignancies. So rather than just looking at leukemia, as some other studies had previously done, they specifically broke it down into subtypes of AML, CML, etc. And they were also looking at the outcomes of those secondary malignancies. So they were drawing from the SEER registry, so from 1973 to 2014, and they were specifically looking at low or intermediate risk tumours of well-differentiated thyroid cancer that have been treated with surgery as one cohort, or those who have been treated with surgery and radioactive iodine. And there was some quite complex risk regression analysis performed to calculate the relative risks of these outcomes. And so when you're looking at the overall data, it was from about a population of close to 2 billion, of which they selected nearly 200,000 thyroid cancers, and then broke that down to about 148 thyroid cancers that were well differentiated and fit the criteria. And then this was one of the issues, that this number was actually incorrect in the paper, so there was actually about another 2,000 patients, and it was due to a difference in the way they classified their observation period, being 1 year or inclusive of the 12th month. So that's now been sort of updated on the latest version online. and that led to some other differences in the data that they hadn't really explained. There were some errors here in that this number here didn't actually add up with the number of patients that have been followed up, and so that's sort of all been clarified with some clarifications on the online version at the moment. And although when you look at the actual absolute numbers of patients who developed a secondary haematologic malignancy, patient years at risk, down here. When you look at the absolute numbers, there actually really isn't any real difference in absolute numbers of malignancies in the two groups. So it really took some quite detailed statistical analysis. Based on the raw data, it wasn't suggestive of any risk, but it required this complex analysis of background secondary haematologic malignancy rates, which was really based on age, sex, even calendar year of the specific background rates for each person year at risk of that malignancy. And so that's what that's how they developed the background risk that it was compared to, and then when they divided the observed number of secondary haematologic malignancies to the expected number, that's how they came up with the relative risks, which I'll just discuss for you now. There were a couple of issues with this is what Mark went through in quite a lot of detail from the supplemental data, and of the ICD oncology codes they used, several of these didn't actually relate specifically to thyroid cancer, but they were classified in as such. So it included some types of bladder cancer, breast cancer subtypes, etc. But in the discussion that followed from the request for retraction, it really was clarified that there are these other qualifying factors, including that all the tumours, so that they may have been misclassified as those tumour types. So they all had to have arisen from the thyroid as well. And the other issue in patient selection was all those patients had to have been treated with radioactive iodine. So that was deemed not to be necessarily a big issue affecting the results. And ultimately, their final results showed, by multivariate analysis, when you compare with thyroidectomy alone, use of radioactive iodine in the lower intermediate risk patients, there was an increase in hazard ratio or relative risk of AML of nearly 2. There was also an increase in chronic myeloid leukemia of about 3.5. But the other thing which should have really been presented quite clearly in the paper, but wasn't, because it was actually a primary outcome, was looking at all specific subtypes of secondary haematologic malignancies, but there was actually quite a statistically significant reduction in multiple myeloma in the patients that were treated with radioactive iodine. But that it just figured in sort of one line buried deep in the results. The other results they looked at, when compared with matched thyroid cancer controls, AML was associated with a shorter median overall survival of 8 years versus those that didn't develop AML, and those matched controls, when compared to de novo AML, this therapy-related AML had a trend toward inferior survival as well, which has been seen in other studies. So this is just showing those results in another way, looking at what they'd presented with those who developed AML in the group who'd had radioactive iodine. There was this early peak just in that first 1 to 3 years, and then it subsided back down quite promptly to background risk. And with the CML group, it showed also quite an early peak within that first 1 to 2 years, and that remained out to about 10 years. And there's some, there were several questions raised about, the validity of choosing the time from diagnosis to development of disease, or whether it was just picked up through higher surveillance of these patients who'd been treated. So there were several areas of controversy that were raised. There were some arithmetic errors that were corrected. There was also the potential of misclassification of high-risk disease that wouldn't have been picked up in the SEER database, looking at either extensive lymphovascular invasion or high thyroglobulin levels. It really was quite biased presentation of results, so they really did ignore one of their other primary outcomes, which was that effect on multiple myeloma. There was no mention of absolute risk of quite a rare outcome, so as we know when we were discussing risk to sort of a general community and particularly patients, it's more an absolute risk rather than relative risk when it's a rare outcome. In this study, there wasn't any access to I-131 doses, so that wasn't assessed. This question about the short latency period, and then also the fact that it did really require quite a lot of opaque statistical analysis to come up with these results that weren't really evident from the raw data. And in fact, when you look in the appendix at the solid tumours, there was actually significantly more solid tumours in the surgery group rather than the radioactive iodine group. But again, that wasn't looked at specifically. But despite that, when you do actually compare this to other major studies, what you find is, there was a large study published from Korea registry, where really what they found was that they also saw at doses over 100 millicuries, significant increase in hazard ratio of leukemia, but they didn't see a significant increased risk of doses under 100 millicuries. There was another study published from a group of 20,000 patients in Taiwan. They also found hazard ratio of 2.7, with the highest risk in those who received over 150 millicuries, so a hazard ratio of 6 in that cohort. And they also did see an increase in secondary malignancies, with an incremental risk relating to dose in that cohort. And then from the US, there was another paper looking at the SEER data previously in 2011 that they came up. They were specifically looking at T1 patients, so very, very low risk. And the key issue that drew them to analyse this was that the use of radioactive iodine in T1 tumours had increased from 3% in 1973 up to 38% use of radioactive iodine in that cohort. So there really had been a significant increase in radioactive iodine in low-risk patients. And again, this informed part of the decision to reduce the use of the recommendation for radioactive iodine in the latest HA guidelines. So we do still find, despite this, the results, although there are certainly concerns with the study, they're not radically different, in fact, to other populations and other studies. And so really, when we do try to analyse this, we have to acknowledge there were clear limitations in the study, but yeah, there is that consistency of a small absolute increased risk in AML. We know that really, most R131 is administered, well, previously in low, but now it's really in intermediate risk disease by numbers. And if we were to work out, well, how would we use this information? Well, certainly adherence to the HA guidelines. It's a different population to what was reflected in that study, which really looked at a period where there was greater radioactive iodine used in low-risk disease. Yeah, it should be used cautiously, but I think we have to consider just how we use it in individual patients and using the lowest effective dose in advanced disease. And I guess a question coming out of it was that, if this patient in front of me were to subsequently develop AML, would I comfortably justify my decision to have treated them? Something just to cross your mind. And it then poses a second question of how can I improve risk stratification to determine suitability or not. So it's, provided that there is a valid reason, then people should be very comfortable about treating them and making that decision at that time. But I think in low risk patients, I think the evidence has swung away from that. And how do we really define this? So this is just drawing the table from the HA risk stratification. We know the low risk, it's really with no adverse features at all. With intermediate risk, we know this is those with either aggressive histology, small volume nodes, particularly in the central neck, or multifocal tumours, etc. And then with high risk, it's those who've got macroscopic invasion of adjacent structures, distant metastases, etc. And when we look at what information we can use to guide our decision making regarding use of radioactive iodine, we look at the guidelines, and clearly it says it's not indicated in those low-risk patients, T1A, so that's quite a different population to what that study we've just presented. But then we've got that big group of intermediate risk, where really, despite being well specified and carefully analysing all the data, it doesn't really ultimately guide us all that much. For all of these, it says, so at the lowest, so tumour size 1 to 4, centimetres, it now says, not routine, but consider if there are other adverse features. But for other groups, including, very large tumours over 4 centimetres, microscopic ETE, central neck nodes, it really does say consider generally favoured, but there are other considerations, including size of tumour or, the number and size of the central neck nodes. So we do still need some discretion here. And then obviously for high-risk disease, gross extrathyroidal extension, distant metastases, it's very clearly recommended. And so part of the reason, in fact, why we are treating is because we actually don't have that data about what is present in the patient's neck. It's an educated guess based on what's been removed and what the histopathologist is looking at, as opposed to residual disease. And so part of the benefit of treating is that we do get a post-therapy scan and adequately stage and see what we have treated. And it moves on to the next question of what other ways can we better inform that decision of treatment. And so consideration of post-operative disease status in radioactive iodine decision making. So from the guidelines, really the use of a post-operative thyroglobulin is something where there's been several studies looking at this more recently, and so tested at 6 weeks, it can help assess for persistent disease or thyroid remnant, because really it should reach a nadir at 3 to 4 weeks post-operatively. With an unstimulated thyroglobulin less than 1, there's really a very low risk of disease recurrence of 1%. In those who've got an unstimulated thyroglobulin greater than 10 to 30, at that point, there's a higher risk of persistent disease, failed ablation, distant metastases and worse outcomes for patients. So in the middle there's a lot of grey area, it's not clearly specified, but it can be a helpful tool in guiding in patients where you're equivocating as to whether or not you would treat with radioactive iodine. And the other one, of course, which is controversial, but it's the use of a pre-therapy radioactive iodine scan. So from the review, certainly in the HA guidelines and brief summary, particularly with I123 or I131 imaging, it can show management impact in 25 to 53% of cases. And this is predominantly, in these studies, is looking at escalating the dose administered because of the finding of persistent disease. There is, particularly with I131, theoretical risk of stunning, and the overall recommendation is to use a low activity and ideally administer within 72 hours of the diagnostic scan. And this really brings in that principle of Theranostics really back to thyroid cancer, which we've seen, and it's more established now in our treatment of neuroendocrine tumours and with studies looking at prostate cancer. But really prediction of response to therapy using a diagnostic test, we're all familiar with this, but using the initial molecular imaging staging investigation to determine suitability for the therapeutic isotope or radionuclide, and then using that same diagnostic molecular imaging modality to assess response and ongoing surveillance. If it is positive, the patient can then be retreated again. And again, really one of the key elements of this is that in those patients that aren't expressing the target on that diagnostic scan, you can then avoid the need to treat them. And so when we talk about radioactive iodine, everyone here in the audience is familiar with the different isotopes. So I131 predominantly for therapy, but also for imaging. There is theoretical risk of stunning. We know the longer half-life and imaging times. I123, the benefit of not having a beta particle, so there's no real evidence of stunning in the use of I123 and better imaging resolution. But given the shorter half-life, we have to image at 24 hours, so we don't get the chance for delayed imaging or dosimetry. And then for I124, used for both imaging and dosimetry, a better resolution, some controversy or no actual real published evidence of stunning, but theoretically it's possible with the positron, longer half-life enabling multi-time point imaging for dosimetry and quantitation with PET. And you can see these are two patients. This is a therapeutic, or this is the same patient, two traces with showing that resolution of I123 and I131, and certainly with I124 we get very good imaging resolution and distribution of disease. That's a different patient. This is just showing that evolution of thyroid cancer imaging that we've seen really from planar imaging. This is a patient from just a couple of weeks ago this is their post-therapy I131 scan, and we've gone through planar SPECT through to PET-CT. This was their pre-therapy I124 PET showing, this is a young patient, multiple pulmonary metastases, and we were able to, quantitate both the dose to the measurable disease, so the nodes was getting over 100 gray per gigabecquerel, and then also work out a maximum tolerable dose to determine, a safe therapy dose for them. When we look at pre-therapy imaging, I131 or I123, so one of the key issues is if positive you can increase the dose, but in those patients where it's negative we are really limited with reduced sensitivity for detection of metastatic disease. So with I123 or I131 you're really only getting about 50% sensitivity for detecting lung metastases, and that's in several studies. And so when you compare that to the post-therapy scan, so if it's negative, you can't use that as a rationale to omit planned therapy. You just can't be confident you're not seeing that metastatic disease. And they've also, with the use of these low-dose scans, there have been studies that have quite clearly looked at the diagnostic value of the thyroglobulin versus the pre-therapy scan, and certainly with I131 there really is little, if any, additional diagnostic value from those studies. But when you use pre-therapy imaging with I124, you can use a low activity, less than 30 megabecquerels, to minimise any theoretical risk of stunning. You get multiple time point imaging, and there's several studies that have looked at this comparison of the pre-therapy scan to the post-therapy scan, and this is the largest one published in 2016. 137 patients with over 200 lesions, and they particularly used the same method of TSH stimulation. So nearly all of them used thyroxine withdrawal for the scan and the therapy, and it showed that when you looked at the I124, it detected 98%, virtually all of the lesions that were seen on the I131 scan, and vice versa. I131 post-therapy scan picked up nearly all of the scans. There was only a couple of patients where there was some minor disagreement. So it's valid for this use, and there's numerous studies that show I124 is significantly better than I131 diagnostic scan. The way that it can be used, now this is sort of the full bells and whistles approach, but you can do blood sampling, so to determine the maximum tolerable activity, to aim to limit the exposure to less than 2 gray. Can use whole body gamma imaging as well, so just getting the patient to stand in front of the gamma camera, and that's just as information those looking at limiting whole body retention to reduce risk of pulmonary pneumonitis or fibrosis if they've got diffuse lung disease. But you have that data, and then 2 time point imaging to determine lesional dosimetry. And there have been thresholds that have been defined based on dosimetry, looking back over many patients and seeing that in the thyroid remnant it's well differentiated tissue and you need to get pretty much close to 300 gray to get a complete response. But metastatic disease in these studies, looking at dosimetry, you don't need as high a dose to get a complete response. These are retrospective studies. And so this is a brief, not sure I'm going for time, but looking at how it can be used. So this is a patient who had presented with near cord compression from a follicular thyroid cancer metastasis to T8. That was resected, and then he had a pre-therapy I124 scan that showed numerous other lesions and residual disease at that site. He got a very big dose. He got 11 gigabecquerels of I131 following that. This was a patient from my time at Peter Mac. And that's the concordant post-I131 scan. And then there was follow-up. He had another scan done about 6 months later. Showed quite a marked response everywhere. And looking at the residual dosimetry, there wasn't going to be dramatic benefit, or the likelihood of getting a response at those small volume residual sites of disease was quite low. So instead of actually, the decision was to withhold treatment at that point. And then instead at that main site of interest where he had the cord compression, that was then treated with external beam radiotherapy at that point. And so he still has the opportunity to have a lot more radioactive iodine down the track if this disease does recur. Now, if we weren't using pre-therapy imaging, someone would have probably given perhaps 6 gigabecquerels of iodine here, and then they would have received another 6 gigabecquerels here, and it would have likely to have been a substantial response. The overall dosimetry to these lesions would have likely been much less. So potential clinical benefits when we look at pre-therapy imaging. Patients without iodine-avid disease, you can avoid the inconvenience of unnecessary admission or isolation, avoid potential side effects of therapy. And there is also a role of accurate characterisation of radioactive iodine refractory disease quite early. In those who do have iodine-avid disease, there is controversy, I won't go into it today, but about the actual benefits of high radiation dosimetry. It seems intuitive that we're looking at a biological response to radiation to induce that, but it's very hard in studies to say, well, giving someone 10 gigabecquerels rather than 6 or 4, it's very hard to tease out that difference, and it hasn't been done. But intuitively, it makes sense. But there is certainly been studies showing that if you do give someone 7 gigabecquerels or 200 millicuries of I131, quite a substantial number of people, particularly those who are elderly, will get above that dose threshold. So it can be unsafe. You can't go up to that level without dosimetry. And so we've got a grant for doing I124 imaging in 96 patients over the next 2 years. And so with our team, we're implementing all of this. We've got a protocol established that we've been doing for the last 6 months. And we're evaluating prospectively, looking at management impact, so between intermodality, adjusted activity or no change to therapy, and looking at a basic cost effectiveness analysis of this. And this is just 2 of the cases showing how it's used. In the early patients we're doing, our physicists had a much more rigorous multi-time point imaging with 3 PET scans, but basically this patient had bilateral acetabular metastases, and a skull metastasis. And we knew in this patient their maximum tolerable activity would be very high, 17 gigabecquerels, and we could see what dose we were getting to each of the lesions. as an estimate, and then that was the post-therapy scan, which was concordant with that. He got 8 gigabecquerels. But this was another patient who was initially treated with radioactive iodine, and on his post-therapy scan it showed multiple mediastinal masses. He was then considered for surgery, but ultimately relating to comorbidities, etc., he was deemed unsuitable for surgery, and he had an FDG PET. It was clearly very intensely FDG avid. The standard practice would probably still be giving him another dose of radioactive iodine to make sure that there wasn't any uptake there. There was no uptake on the initial scan, but you could theoretically think it could have all been taken and sucked up by the remnant. So, but we did, this is the sort of case where we tend to use these, where you can then work that out, and if there's no uptake, rather than just getting a negative post-therapy scan, which we would see in probably 50% of patients, or particularly if there's a high thyroglobulin, in his case we could conclusively show that there was no uptake in that large mediastinal mass, and we'd be delivering no dose to that. And so then we just put him back on his thyroxine, and he avoided an unnecessary high dose of radioactive iodine. Looking at thyrogen and metastatic disease, the question really, there was this big study published about 2 years ago looking at does recombinant human TSH stimulated I124 PET predict the findings of a thyroxine withdrawal stimulated high dose I131 post-therapy scan. This would be great if we could just give everyone a thyrogen stimulated PET to determine suitability. They wouldn't need to withdraw a thyroxine. It was a prospective study, multi-centre observational cohort study. The inclusion criteria were patients with an elevated thyroglobulin and negative neck ultrasound who were planned for blind therapy, and the primary outcome was the number of futile I131 therapies admitted. Now, the study was stopped prematurely after just 17 patients, because although 8 patients had negative post-therapy scans, and of the other 9, 9 of them had positive post-therapy scans, but of those, only 4 of them were predicted by I124. So there were 5 patients who had a negative thyrogen-stimulated PET scan, but yet had a positive post-therapy scan. And this is an example here showing a lesion, a right retroclavicular node that wasn't seen on the I124 PET. And this was a patient who had a metastasis in C2 that wasn't seen on I124. So really, when using thyrogen in this study, it showed a sensitivity of only 44%. And the key question is really, is it biology or is it technology that's determining that issue? Because there were 2 variables. You're looking at a PET scan and a post-therapy scan, but you're also looking at thyrogen and thyroxine withdrawal. And one question or one discussion point is saying that the I124 PET is used as a theranostic test rather than a diagnostic test. So potentially, if it was just a technical issue and it was a very, very faint focus you didn't see on the PET, the likelihood of delivering a clinically meaningful radiation dose would be low. But looking at biological, other issues, could it be just imaging resolution? It's possible, but studies have looked at, phantom studies can show that there's actually no difference in resolution. Different imaging times, unlikely, because the patients were imaged at 24 and 96 hours. And so it was felt, we wrote a letter in response to this saying it was most plausible that it's a different biologic response to TSH stimulation. Because we've had numerous studies showing if you withdraw, like I showed earlier, if you withdraw them and do an I124 PET, it's very concordant with the post-treatment scan. And the authors agreed. And there's numerous case reports and even prospective studies, which I won't go through in great detail here, but who clearly show within the same patient, if you do thyrogen I124 PET and then have subsequently done a thyroxine withdrawal PET, there is significant difference. And so, that happened in one of the THYROPET patients, and there was a 23-fold increase in I124 uptake on their thyroxine withdrawal one. And there's more recently this study in the Journal of Nuclear Medicine showing, this was a prospective study in just 3 patients, but showing significant increase in uptake with thyroxine withdrawal. So generally, the recommendations fit with the guidelines, which are there's insufficient evidence to use thyrogen in metastatic disease, but obviously if patients can't undergo thyroxine withdrawal, it's appropriate to use thyrogen. So in conclusion, really, I think this shows there's a need for collective vigilance and scientific scrutiny of nuclear medicine-related publications in the general literature. That doesn't just apply to this one in the haematologic literature, but also in cardiac nuclear medicine as well. We've seen that previously. I think it is plausible that there is this small increased risk of haematologic malignancy following radioactive iodine. And I think it is important to use further ways to deliver precision medicine through using risk stratification to ensure treatment for those most likely to benefit. So whether that's greater use of post-operative thyroglobulins or consideration of incorporating pre-therapy imaging. And I think it is important to recognise that it is likely that thyroxine withdrawal stimulation is preferred to thyrogen in the setting of metastatic disease. This is completely different, and I should distinguish that to when we're treating patients where it's remnant ablation for a thyroid remnant. So we've got RCT evidence supporting our use of it in that situation, but this is really specifically looking at patients with metastatic disease. So thank you.
Thank you, David, for an excellent presentation. I'm sure you've all got questions for David, but can we hold those till the end? And hopefully Bill will make up some time. So we'll pass on the baton to Bill, and he can speak very quickly.
Ever the optimist, Sam.
Thank you.
Okay, so look, I've got a lot of slides. There's a bit to present here, and so I'm going to motor through them. So I'd just like to walk you through some of the outcomes from the MBS review into nuclear medicine, which has submitted its report to the task force now. So MBS was introduced in 1984, originally Medibank, but rapidly changed to Medicare, and there are over 5,500 items on the MBS, most of which have never been reviewed since the MBS was initially published 30 years ago. So the then Minister for Health, Suzanne Ley, in 2014 requested that there be a review of the MBS to ensure that it was contemporary, was guiding best practice, was providing value for patients and financial value for government, addressed any areas where the MBS was being improperly used, and out of that, if any new services were identified, that these could be forwarded to the to MSAC for consideration. So this is a slide from the department. The MBS is pretty big, and you can see here that nuclear medicine in the corner consumes about $250 million worth of services per year. But that's a relatively small proportion of the total of $21.1 billion. And what I hadn't been aware of is that the big daddy in imaging is ultrasound, not CT. And use of MBS services is growing both in number of services and in the cost of those services, and you can see that diagnostic imaging is growing at around about 7.5% per annum, which is similar to most of the other areas of the schedule. If you look at nuclear medicine services in Australia since the statistics were being published, they have been going up steadily over time, and a fairly steep increase that we saw from about 2006 through to about 2015 was driven in large part due to the introduction of the 61505, that's the CT for anatomical correction and localisation, attenuation correction and anatomical localisation. But a fairly steady growth in services during that time. Now, obviously a review, most people sort of concentrate on the potential threats from that. Is this going to wipe out my practice? Is what I have traditionally done going to be declared illegal or non-kosher? But there's also opportunities that can arise out of these, and so when you participate in these, you have to be mindful of both. So the task force was formed in 2015, and it's headed by Bruce Robinson, who's the Dean of Medicine at the University of Sydney, and it consists of 18 committees, one of which is the Diagnostic Imaging Clinical Committee, and the Nuclear Medicine Working Group is a component, a subcommittee of that DICC. And the DICC has been charged with reviewing all of the radiology and nuclear medicine items, and so that would be categories 2, 3 and 5 of the MBS schedule. And It's important to note that a number of other groups have also been given licence to fiddle around with imaging items. So the Cardiac Services Clinical Committee, as many of you would be aware, reviewed cardiac imaging services. The Diagnostic Medicine Clinical Committee, which is a more recently promulgated committee, has been charged with reviewing imaging and pathology from a referrer's perspective, primarily general practice. There's another body called the Principle and Rules Committee, which looks at things like sort of co-claiming and self-referral and things like that, and I'm not aware that they've published their report yet. There's been a recently formed Consultant Physicians Committee. I'm not quite sure what their brief is, but there are a number of committees and they all publish reports, and some of their space is sort of slightly overlapping. And then the Nuclear Medicine Working Group, which was formed as a subcommittee of the DICC, consists of myself and a number of other fellows of the association, plus some educated sort of referrer participants. So Jill Duchesne is a radiation oncologist from Melbourne, Michael Feenley, a cardiologist from Sydney, and Rachel Mooren, who was a health economist at Curtin University, originally was a nuclear medicine technologist before she took up her academic career. And we had secretariat support from MPS Medicine Wise, which is based at Surrey Hills in Sydney. Some of the other committees within the MBS got a slightly more Ferrari-like secretariat support from Mackenzie's, but we didn't. And it's important, those of you who've worked in government would be only too well aware of this, but for those of you who haven't, once we formulate our report and make recommendations, the process by which they can get approved is very long and tortuous. And we're only at this point here, so we have established the committee and we've undertaken a review and published a report which is imminently to be released for consultation. But then there's a process of considering feedback. That then is a dialogue between ourselves and the task force. The task force is the one who ultimately makes the decision. That then makes a recommendation to government, either through MSAC or directly to the minister. And the minister is the person ultimately responsible for approving or not those recommendations, with the goal being a better MBS, at least from the government's perspective. So there are 18 committees, more than 30 working groups, and hundreds of clinicians which have contributed to this process. Our report has been endorsed by both the DICC and the task force and is imminently for release. Unlike some of the earlier reports which were released to the general public for consultation, and some of those reports generated huge amounts of response, the Minister has requested that henceforth all of the task force reports be submitted for targeted review to appropriate parties. Now, in the case of the Nuclear Medicine Working Group report, that would almost certainly involve the Society and the Association, the AANMS, and groups like RANSCA, probably ARPANSA, and I'm not sure who the task force will choose to submit this report to, but it will not be available for the general public on a website for response. And it's expected that the consultation on these recommendations will take place through the middle of this year. I would expect that we would be reviewing those findings around the end of, in the second half of the year. Now, when we formed this committee, it was important to approach this with some kind of strategic framework, and clearly from the government's perspective, point number one was the most important, which was to review the existing nuclear medicine items to ensure that they were both current and valid. So were there any redundant or superseded items? Was there any clumsy or outdated or ambiguous wording of the item descriptors? Were there any restrictions in place on current item descriptors that were no longer appropriate to modern clinical practice? Were there any MBS rebates that were hopelessly out of step with current financial situations? And were there any areas of inappropriate practice or claiming, and we used data submitted by the department for that? But also, looking towards the future, I felt that there was a need to increase the availability of PET services beyond the current limited indications, given that these were formulated in 2001 and 2006, so no recent update on the indications for PET in this country. And also to anticipate the growing role of radionuclide therapy and Theranostics, as both of the previous speakers have alluded to. So we got 107 nuclear medicine items to review, and we made 22 recommendations in our report. Of these, 17 items have been recommended for deletion from the MBS, almost always because they are just never used anymore. 49 items were recommended to be changed. Most of that change is in minor changes to the wording. For example, some item descriptors stipulate that you know, you can do this with SPECT or SPECT-CT or planar or anything you like, and that then becomes a redundant paragraph. And so to simplify the items, we've sometimes recommended that they be removed, and that 41 items should be left completely unchanged. So of the items to be deleted, this is the list of the imaging items. And I should say that from the outset that the DICC has recommended that all NK items be abolished. Now, NK items are items performed on old machines that are beyond the capital sensitivity used by date, which in the case of nuclear medicine is 10 years or 15 years if you've had an upgrade of your camera. And so any studies performed on machines which are older than 10 or 15 years will no longer be reimbursed by Medicare, and this is the case all across diagnostic imaging. There will no longer be a Medicare rebate payable for services performed on outdated machines. But even those services performed on current machines, for example, a testicular scan, now that's been completely replaced by ultrasound. There were no claims for a testicular scan in financial year 2014-15, so that's a redundant test. Blood-brain barrier study has been almost completely replaced by CT, and most dynamic blood flow studies have been replaced by ultrasound or angiography. So these are services which hardly anyone performs and which Australia won't miss if they're no longer reimbursed by the MBS. There were other services that we recommended be abolished where, for example, there was a choice between planar and SPECT-CT imaging, but really everyone these days would perform SPECT-CT, and there's little role for the planar imaging version of that study. So liver and spleen colloid scan, not very often performed anymore, but still sometimes has a place. Well, everyone would do SPECT-CT if they were doing one of those. So the planar item can be abolished without affecting services to patients. And the same with thallium scans, occasionally performed, particularly in a couple of sites, and adrenal studies. So some of the items that were recommended for abolition don't mean a disappearance of the service, it just means a restriction on how you can perform that scan if you want the government to pay for it. And then there were a number of non-imaging items, again, which you can see very low volumes of service in 2014-15. The country won't miss these if they're no longer funded by Medicare, and I can't remember when I last performed any of these. This is a mysterious study. No one could actually figure out what this was, and in fact there's only one place in Australia doing it much, so if you come from that site, the government's not going to pay for it anymore, but I have never reported one of those. Then the NK items I've alluded to, so as you can see here, in nuclear medicine, these NK items performed on old machines comprise less than 0.1% of studies. So there are very, very few of these performed which are billed to Medicare. Cardiology was an area of considerable controversy, and I put this slide up. This comes from the CSCC report, so this is publicly available. Because the CSCC, the Cardiac Services Clinical Committee, made quite a noise about the uncontrolled growth in cardiac imaging services. And you can see here that the principal driver for that has been stress echo and more lately CTCA, and that myocardial perfusion scans have hardly grown at all over the period under consideration. Which means that the decision, okay, and we'll come back to that again. We all had a look at gated blood pool scanning, and there are 5 item numbers there, and we decided that it was easier to reduce these to 2. So these 3 items here would disappear, but be rolled into that item. So gated blood pool scans would then be a simple basic equilibrium gated blood pool scan to determine ejection fraction, or anything more complicated than that. This shouldn't really affect people's reimbursement at all. Not many of these scans are performed compared to the 11,000 performed in the more common categories. And the rebate here for this more complex scan is sort of in the middle of the range of what was available for those scans previously. And we also recommended that there should be no longer any reference to whether or not it was a planar or a SPECT scan, that would be up to the practice. Now, getting back to the growth in cardiac services, it's a little bit perverse that out of this concern regarding the uncontrolled growth of stress echo, the final conclusion of the CSCC report, which is not yet published, is likely to be that there be restrictions on the availability of myocardial perfusion scanning, but no restrictions on the availability of stress echo. And there's a very tortured political process by which things have arrived at that point. I never want to hear the words nuclear cardiology again, but the chair of the task force, Bruce Robinson, has heard the arguments from both of the committees, and I am pretty sure will have decided to accept the cardiologist's argument that stress echo is cheaper and involves no radiation, and is in most patients, or many patients, clinically equivalent, they would argue most, and that therefore it is the preferred test. So if we go to here, stress echo is to be preferred unless the patient is unsuitable for stress echo. That might be because they have the wrong body shape, or they have irregular heart rhythms or LV dysfunction, or they can't exercise. And I don't know about you, but this would describe the majority of the patients that we perform MPS on anyway. And importantly, what was mentioned in the cardiac report, but which is not detailed in their recommendation, is that the cardiologists acknowledge that where the quantification of the ischemic burden is required, that MPS is a superior technique to do that. The gatekeeper role of stress ECG, I think, is probably dead and buried, so it will no longer be a requirement for patients to undertake an exercise treadmill test before they can be referred for cardiac imaging. But these are my expectations, and the final cardiac report is not yet published. Now, I just wanted to go back to fee restructuring for MPS. So the cardiologists argued that if you did a stress MPS and then a few days later did a rest MPS and billed them separately, that the total came to more than the fee for a combined MPS, and it's true. And so we, I guess, sort of fell into line with them in agreeing that there should be no financial incentive to split the studies into two, that you can do a 2-day combined MPS, or you can do a same-day combined MPS, but that the fee for the two should be the same. We also had a look at their recommendation, which was that the fee for the exercise ECG be rolled into the imaging item. And if you do that, the combined fee for the nuclear imaging plus the exercise ECG comes to $987. And we then were left with the decision about whether or not that should be split 50-50. In other words, would you have the same fee for a rest MPS and a stress MPS with one of them having the exercise ECG included, or should we try and adjust the fees to incentivise stress-only myocardial perfusion imaging and to make that a worthwhile goal for practices in Australia to pursue? Given that the INCAP study has shown that in Australia we do very little of this, we're one of the countries that does the least of it in the world. And so out of that, we decided that it would be reasonable to propose splitting the fee, given that the stress side of the exam is a much more complicated exam to do. 2/3, 1/3, with 2/3 of the fee going for the stress MPS plus the exercise ECG, and 1/3 for the rest MPS, with the total remaining the same. And by the way, 95% of practices in Australia do claim this combined MPS fee, so 95% of practices will not be financially disadvantaged by this at all. So that was a long-winded way of getting to what the recommendation in the report will be. Now, we had a look at high-cost radiopharmaceuticals, and in this process we had some discussions with the Pharmaceutical Benefits Advisory Committee, and they are open to the idea of listing therapeutic radiopharmaceuticals on the PBS, which means that we would simply write a prescription for them, we'd be paid a fee for administering them, but the cost of the radiopharmaceutical would be borne by the PBS. And so the pharmaceuticals concerned in which the current MBS fee doesn't meet the price of the pharmaceutical, and therefore no one does it, are those. But in the interim there would be a need to increase the fee for these so that the cost of the fee matched the cost of the radiopharmaceuticals. The PBS, however, were not prepared to undertake this for diagnostic radiopharmaceuticals, which the cost of which has to stay on the MBS, and certainly there are two, indium-111 DTPA and I-123-MIBG, where the cost of the radiopharmaceutical exceeds the MBS fee, so there needs to be a fee increase to allow these still to be performed, and we felt that they are both still clinically relevant examinations. Gallium-68 octreotate PET-CT has now largely replaced indium-111 octreotide SPECT in this country. It's more accurate, it performs the job with a lower radiation dose to the patient, and it's cheaper to perform than indium-111 octreotide. MSAC accepted this argument in a fast-track evaluation and recommended to the Minister that this be that gallium-68 octreotate replace indium-111 octreotide for somatostatin receptor imaging, and that's been approved, and it's going to come into play in about 2 weeks' time with a new item number 61647. However, it's important to understand that this replaces indium octreotide in the existing item number, so it's for GEP-NET tumours only, for pre-surgical evaluation. And so some of the gallium octreotate PET scans that are being performed for response assessment and for restaging of patients would not be covered by this item, and that will require a separate application to MSAC for an expanded item, item number. However, it is I think an important advance, and out of this a couple of other things were achieved. The first is that the TGA has accepted that this extemporaneously compounded substance can be reimbursed under the MBS, and so that opens the gate for a whole lot of other extemporaneously compounded substances to receive the same treatment, including therapy isotopes. And the second is that MSAC have now accepted the principle of radiopharmaceutical substitution, which means that if similar things come along in the future, that we'll be able to swap a newer radiopharmaceutical for an older one without going through the entire exhaustive MSAC process again. FDG PET, we've recommended for a major overhaul. Whilst we were undertaking this review, we received a communication from the Oncology Committee saying that in their view, We should fall into line with the funding arrangements that exist in the United States and in the UK, where all FDG-avid tumours are covered for reimbursement. The rules are slightly different in the two jurisdictions. In the US, it's all solid tumours except prostate cancer. In the UK, it's all FDG-avid tumours without going through a long list of what those might be. And we have proposed that there be 4 item numbers to replace the current 20 and that they apply to all FDG-avid tumours for the purpose of diagnosis, so something like a solitary pulmonary nodule, for example. For staging, something like lymphoma or lung cancer, as we currently do it. For response assessment, I don't know about you guys, but we do a lot of response assessment scans and they're being embraced by clinicians but are not reimbursed most of the time except in lymphoma. And for restaging of suspected disease recurrence. No one believes that we should be funding PET scans for surveillance in clinically well individuals, and no other countries in the world do that. And so a joint submission from ourselves and from the oncologists is going to go somewhere. I'm not sure yet whether it'll be to MSAC or directly to the Minister to this effect. It won't happen overnight, but I think it's a direction that we should proceed in. Contrast CT got a bit of a mention because some practices are claiming a lot of contrast CT, about 20% of PET performed in Australia is performed with contrast CT, and there are times when that's entirely appropriate and other times when it might not be. But contrast CT does involve a higher radiation dose to the patient. There's the small potential for toxicity from the contrast itself. It's more expensive. And lots of patients that we perform PET scans on have just had a contrast CT examination, and there's no clinical justification for doing another one. So we have recommended that this be funded by Medicare when it's been specifically requested by the referrer. For example, an ENT surgeon might request a contrast CT at the time of PET prior to planning head and neck surgery. Entirely appropriate. And if the patient hasn't had a contrast CT exam the week before. Now, given that we think that there are occasions when contrast CT is appropriate, we haven't been able to come up with a regulation that corrals the use of that, and this has been something which has been left to the audit functions of the Department of Human Services to police. CT for anatomical attenuation, correction and anatomical localisation is sometimes claimed by people performing PET scans, even though that's specifically forbidden in the regulations if you read them. However, the item descriptor is a little bit ambiguous in this regard, in that it gives a range of nuclear medicine items that you can use for co-claiming, and embedded in that are the PET items. So you've got to consult 2 pages to realise that the PET items don't qualify. So there's going to be an amendment to the item descriptor for 61505 to specify that it's only for nuclear medicine items spec'd. The PET items fall in between these 2. Other PET issues, so we had a look at FDG PET for cardiac purposes, and we were advised that MSAC had recently recommended against funding MRI for both myocardial viability and for cardiomyopathy, and that there was almost no chance of success if we put up a proposal to fund FDG PET for these purposes. So we chose to pick our battles on that. And PET cardiac perfusion agents, there aren't any currently available in Australia, and so it would be a bit weird to recommend that we fund something that no one can actually do. PET for cognitive impairment. Some people would say that we missed an opportunity here. It's, I think, for most of us, considered the gold standard in nuclear medicine. However, it's previously been rejected by MSAC not too long ago, and it's also been rejected in the United States, both on the grounds that there's no impact on outcomes because no effective therapies are available for these conditions. In addition, there are a couple of meta-analyses out there which don't show that there's a huge advantage of PET over SPECT, and we took the view that another proposal to push this forward may well meet the same fate as the earlier ones. However, you might choose to disagree, and you can put that in your responses. Gallium-68 PSMA PET-CT is up and coming, but it's still in the research phase, and I think it's premature to go for a listing on the MBS at this stage. They would simply require more data than we can give them at the moment. It's also not listed on the Australian Register of Therapeutic Goods, but the gallium octreotate example is encouraging that we have a mechanism to get around that. And we've recommended that we should have ongoing discussions with both MSAC and the Department of Health regarding the whole prostate cancer theranostic space and how we should best go about applying for rebates when the time is appropriate. In surspheres, surspheres are currently approved only for inoperable colorectal cancer in the liver, but there are a whole lot of other tumours in which they work perfectly well, and we've recommended that the range of indications for CERT be expanded, in particular to include patients with HCC, where there is some trial evidence that they are superior to sorafenib and other targeted therapies. Therapy radiopharmaceuticals in general terms, as I've said, we have recommended that they be transferred from the MBS to the PBS, and we would simply write a prescription. And we've also asked the Department of Health to go back to radium-223 chloride, which was recommended for funding by MSAC, but negotiations between the government and the distributor broke down, and it just sort of fell into the too hard basket, and I think that that's a lame excuse. Their job is to sort these things out, and they should go back and have another try. High-cost radiopharmaceuticals we've spoken about, and then there are some outstanding issues, particularly related to this Theranostics process. So we need an MBS item for lutetium octreotate therapy. It's been approved in both the US and in Europe, and will shortly receive some sort of funding there, although I'm not sure that anything's been finalised there. The company which markets that product in the Northern Hemisphere doesn't have an applicable patent in Australia, and so that leaves us with the room to extemporaneously compound it, as we are currently doing. And if the government is prepared to fund extemporaneously compounded gallium octreotate for PET, then they should be prepared to fund extemporaneously compounded lutetium octreotate for therapy. But we need to have a discussion with all of the players around that. And then once that's occurred, there will be an identical discussion around PSMA.
The ANZSNM annual general meeting starts here 5 minutes ago.
Oh. So my apologies. So the red cards. So I think last slides. Much of conventional nuclear medicine has been left relatively unscathed out of this, with a small kick in the shins to cardiology. And I think that we have some promising potential pathways available for PET and therapy as a result of the review. So there are some threats which I think we've largely staved off. I hope that we are at the start of some opportunities, and if you want to make any feedback to the reviews, there are the places you can do it. So thank you very much.
I'd really like to thank Bill for his huge effort on our behalf and the association and all the other people who contributed to that. And I'd also like to thank all the other speakers today. They've done a fantastic job. Thanks very much, and sorry, Dale.